I'm from Concord Hospital. I've been a staff specialist there for a long time. Today I've been asked to talk about what not to miss on a chest X-ray. So I've divided the talks into two parts. The first part is mainly just talking about how you approach reading a chest X-ray and a different number of projections you could ask for when you write on your request form, depending on the clinical scenario. And in the second part, I'm going to put in some clinical scenarios with the accompanying chest X-rays, and we'll run through what you should be looking for and what not to miss, I guess. So chest X-ray is probably the most common radiological examination you guys will request, no matter what rotations or terms you do. Certainly when I come in on Monday, there's usually about 150 to 200 chest X-rays to report from the weekend, so it's certainly pretty much our workhorse for the department. So say Mr. Bloggs come back in, has returned from radiology, and you ask to look at this chest X-ray. Where do you start? Do you look at the black bits? Do you look at the white bits? Do you freak out, run out of the ward, ring your registrar? What do you do? So what I would do is obviously first just check for the details. So making sure that you are looking at the right patient, checking the MRN, because patient can share similar names with very similar spelling. So you make sure you check the date of birth, the MRN, and the gender of the patient. Then next, I'll check to make sure the time and the date is the scan that I'm looking at, because even though it's the same patient's X-ray, they've actually might be done a couple of years ago, or even on the same day. But some patients, especially in ICU or even in ED, they might have multiple chest X-rays in a day, depending on looking at line positions, or maybe the patient's condition to deteriorate. So you've got to make sure that you are looking at the most current examination. Then the types of projection. How many types of projection do we know on chest X-rays? Anyone? So usually, I guess most people look at the frontal, what we call a PA or AP film. So the letters PA and AP means posterior anterior. So posterior anterior means that basically the film is at the front of the patient. The beam actually comes from a back to anterior, posterior to anterior direction. Whereas with an AP film, then the cassette is at the back, and the X-ray is actually coming from anterior to posterior. So that's how you tell the difference. And the PA projection is what we ideally want to get the patient as well, because it gives you a much clearer picture, as I'll show you later on. And also the heart size is not magnified, and the 50% rule is what usually people use to determine whether the patient has got cardiomegaly in an adult patient. And then also adequacy. Adequacy of an X-ray basically means that you have to cover the area that you're interested in. So on a chest X-ray, ideally you want to include at least the top part of the clavicle and past the diaphragm. Ideally, you include both costophrenic angles. If you don't have that in a cranial caudal dimension, you haven't got a complete chest X-ray. You also want to make sure that from lateral, medial lateral point of view, you actually include also that lateral costophrenic angles. Sometimes in ICU patients or patients who are really unwell, it's very hard to get an adequate chest X-ray because they're slumped to the side, they're rotated. But ideally, you should really get a full look at the lung fields. And then after you check all that, apart from adequacy, apart from the area, you also want to make sure the exposure is correct. So even in a well-exposed film, you're supposed to be able to see the spinous processes, especially in that mid-thoracic level. If you don't, that means the film is either under or overexposed, and that means that you can actually obscure some pathology. You also want to make sure the patient is not rotated, ideally, because if they're rotated, that also will change how you interpret the lungs. If you rotate to one side, then one lung will actually appear blacker than the other. So on the frontal film, I'm not going to go through in detail exactly, how you're going to assess every single structure, because there's a lot of overlapping structures, and it takes years of seeing normal chest X-ray to determine what's abnormal. But just from my perspective, I usually go from inside out, but you can go from outside in as long as you're systematic. So I usually start with the heart and what's behind the heart, and then I look at the medius hilum and the mediastinum, and then I move up to the lungs, and I look at the bones and the soft tissue. That's just to cover all area. The review areas that people sometimes forget is behind the heart. So you want to make sure that the right side behind the heart is the same density as behind the left side of the heart. If one bit is more whiter or blacker compared to the other, then there's pathology behind the heart. Behind the left heart border is usually in the left lower lobe, so usually obscures the left hemidiaphragm as well. If it's behind the right heart border, then it's usually in the middle lobe. The other review areas you'll also want to check is the apices. Sometimes you can have pathology that's a bit obscure because people sort of forget to look up at the top because there's a clavicles in the way. Also the axilla, sometimes you might see a bit of a bulge. So it indicates an axillary mass, and also underneath the hemidiaphragms. Okay, so on the frontal X-ray, basically you get the trachea, which is that lucent tubular structure in the middle. Then, sorry, I'm sort of facing this way. I hope it's okay, you guys can see. Then this knob is the aortic arch, and then this little indent line that goes down from the aortic arch to about this point to the left hilum is the left atrial appendage. So you've got left atrial appendage enlargement. You basically, instead of having this nice convex line, you'll have a concavity. So that will suggest this like left atrial enlargement. Then this left heart border is made up mostly by the left ventricle. On the right side, the right atrium makes up most of the right side heart border. And then you go up again, there's a right hilum is around here. If the ascending thoracic aorta is dilated, you usually see a bulge as well. And that's why sometimes, it's also like a similar bulge depending on how big it is. But if the patient doesn't have a dilated aorta, you might not see that. Okay. So this is a lateral projection, which is probably the other common projection you guys are going to see. I've labelled some vital structures. So the lucent structure again is the trachea, you can see here. And then aortic arch. Again, you're not seeing the ascending thoracic aorta very well because usually there is normal in size, but if it's dilated, then you get the white opacity filling in this retrosternal window. And it goes down, aortic arch, and then descending thoracic aorta. If it goes further back, the white thoracic aorta, that means it's like an aneurysm or the descending thoracic aorta. The posterior heart border is mainly made up by left ventricle inferiorly and the left atrium superiorly, and the right ventricle makes up most of the anterior heart border. Also, the other place you should look at is the spine. You get limited views of the thoracic spine, but because the lungs, the lower lobes are bigger, so there's usually more air in the lower lobes, you should actually see the spine's getting more blacker, or there's less white as you go down the thoracic spine on lateral projection. If the spine is actually getting whiter as you go down, then it suggests there's actually lower lobe pathology on either side. So then you go back to your frontal and work out which side it is. So as I talked about before, you ideally get a PA film, but occasionally you have to get an AP film if the patient in this situation, if the patient is unwell, they can't stand up. Usually if they're sitting down, you probably have to do an AP film because we need to project the cassette behind their back. You can see here, this is a PA film on one patient, and this is the same patient but with an AP projection. So you can see it's a lot more blurry on the AP film. So that's ideally not what we like. But obviously the patient's unwell, that's what we have to put up with. So you're not seeing a medius dynamis looks wider compared to a PA film. The heart border, the heart size is also bigger compared to a PA film, so the 50% rule does not hold on an AP projection. You're more likely to get rotational artifacts, and also a patient is less likely to breathe up if they're not standing up, so the lower zones will get obscured. So in this case, you quite think, is there left lower lip pathology? They've got consolidation, when in fact actually they don't, because they're basically taking a very poor breath in. So lateral decubitus film is probably a bit less common. We tend to do that mainly if we're concerned that an unwell patient has got pleural effusion. So we tend to lie them down on the abnormal side. So lateral decubitus film, sometimes you'll see what they call right or left lateral decubitus, so which side they're lying on. So the side they're lying on is basically what's designated. So if they're lying on the right side, which is in this case, is a right lateral decubitus film. If they're lying on the left side, it's a left lateral decubitus film. So if there's a pleural effusion, a small pleural effusion, and you can't get a lateral projection because the patient is unwell, you get them to lie on the side that you're worried about, and then you should see the meniscus along the bottom. Also in a child, because it's hard to get them to be cooperative at times, they're alone take a breath in and do an expiratory film as well, you get them to lie on the side that you're concerned about. If you're usually on a normal patient, if you're lying on your side, your lung's not going to inflate as well as the side that you're not lying on. So in this case, if in a normal patient, the right lung usually does not inflate as well as the left side, just because you're lying down. But if there's air trapping, if they've had a foreign body lodged in their bronchus where the air cannot escape, both sides will actually look of similar volumes. So that's another way lateral decubitus film can be useful. And inspiratory and expiratory film, sometimes we get that on request. And in what situation do you think that will be useful? Yeah, pneumothorax is probably what is most common, because again, if The lungs will increase in volume in inspiration and decrease in volume in expiration. So ideally you want to see a change in volume on the inspiratory and expiratory film. But this looks relatively normal on this inspiratory film. But then you get an expiratory film, and then what do you see? You get a pretty big left pneumothorax, the lung edge is here. So if you worry about pneumothorax, you will obviously do both films, but you should also ask us to do an inspiratory expiratory film. If a radiographer is quite experienced, even if you don't write that on the request form that you want expiratory film, but you could put question mark pneumothorax, usually we'll do both. But if you've got a junior radiographer on a weekend, they might not do it unless you ask for it. So just keep that in mind. So with a pneumothorax, you want to see a lung edge, and then you want to see outside lung edge, no lung markings. You can see lung markings quite nicely, like vessels, lung markings, but actually outside of the pneumothorax, it's just air, just black. Rib views is probably another one that we do mainly for trauma situations. It's an oblique projection where you actually see almost the entire posterior aspect of the rib in view. So actually we'll ideally pick up fractures if there are any. Having said that, rib fractures are very difficult to pick on X-ray as well as CT, and it's usually a clinical diagnosis. So just because you don't see a fracture on an X-ray or on a CT doesn't mean the patient doesn't have a rib fracture. But it's just something to help if you're concerned. Mainly CT is not usually looking for rib fractures, it's usually looking for associated injuries, such as splenic injury, hepatic injury, renal injuries. And this is a lordotic view. So lordotic view is probably something that you won't usually ask for unless you do a respiratory term, mainly looking for patients with question mark tuberculosis or known tuberculosis. So basically the clavicles are moved out of the way. So if you, say, go back to, say, even a normal PA film, usually the clavicles are here. But on a lordotic film, the clavicles actually move upwards. So actually you can see the apices really nicely. Basically you're looking for an apical lesion because tuberculosis, a lot of times they get abnormalities in the apices, which could be missing depending on how big it is. So lordotic is usually what we use for those TB clinics. And so this patient, do they have any abnormality in the apex? They've got a right apical mass. Yeah, you compare this side to the other side, certainly more full. Yeah. And in this case, usually we go on to do a CT to further characterise the lesion. So any questions so far? Sorry, I sort of rushed through it a bit. I thought I'd just try to show you as much projection as you can so you can know what to ask for depending on what the patient has got. So we'll move on to the second part of the talk. I want this to be a bit interactive if possible. So the clinical history is written up the top. So it's a 52-year-old patient post-op. You're asked to check the NG tube position, which is very common. Usually after you put in a tube or lines, you'll do a chest X-ray to make sure, firstly, where it is, and also check for a pneumothorax. So what do you think of the lines or the nasogastric tube? Is that in a good place? No, it's in a bad place. Yeah, this is not what you want. Yeah, so very good. So where do you think it is? It's gone down the right lower lobe bronchus, hasn't it? Yeah? So if you don't do an X-ray and check, and then you start to feed the patient, they're going to have bad pneumonia. Right? Depending on how sick they are, they could die, right? So it's very important that after you put a line in, get a chest X-ray early, check it before you start telling the nurses to use it. So in this case, usually you'll need to retract it. You can either move all the way back and then reinsert, or you can take it all the way out and reinsert. You also, I think there's... So basically, apart from looking at what we talked about, looking at the lungs, the heart, the hilum, mediastinum on any chest X-ray, you also got to make sure you look for any foreign bodies. So in this case, any lines that we put in as doctors. So nasogastric tube, endotracheal tube, vascular access, all of those lines, you need to make sure they're in the right position. And the other, the complication you look for apart from that is not in the right place. Even if it's in the right place, you should also make sure, particularly with vascular lines, that there's no pneumothorax, especially if you do jugular venous or subclavian venous catheters. It is not uncommon, it is a known complication to get a pneumothorax, so you make sure you need to check for those as well. So okay, here's another line position check. So this time I think it's a central line. So is it in the right place? No. So it's all curled up on the right side of the neck, and you can't even see the tip, so it's probably somewhere up there. So, you'll hopefully think the person who put it in would know, because it's obviously quite high up. But sometimes you might just have it curled up here, or even it actually goes back into the axilla, which they won't be able to know. So again, you need to check to make sure that it's going to the right place. And ideally, where's the central line should be, where should it tip be? Usually distal, in SVC, just before it goes into the right atrium, ideally that's where you should go. Occasionally they go into the right atrium, but I think usually they prefer it not to be in the right atrium. I have known people who usually have used it if it's in the right atrium. So usually you want to be going straight down and ending just below the right main bronchus. So you can see trachea and then the right and left main bronchus. Ideally you want to see it just past the right main bronchus. That should be the ideal position where tip is. So this patient has got a cough and is desaturating. Is it normal? No? Shaking your head? Where's the abnormality? Left, right? Sorry, right? Did someone say right? So, as I talked about review areas, you want to look at the heart. Yeah, it should be the same density all the way across. So you can see here, this is more white in the medial aspect compared to a lateral aspect on the left side. So there's left lower lobe pathology. Usually we also want to see the hemidiaphragm, a nice clear line all the way across. And again, the medial aspect of the hemidiaphragm, you're not seeing it clearly. So you don't actually know where it starts and where it ends. We can sort of see it laterally here. Certainly that bit looks normal. But where the opacity is, that's abnormal. So you can always confirm, how can you confirm that what you're seeing is a real finding? Just say you're sort of starting out, you're not really sure whether you're making it up. Yeah, get lateral. A lateral will be very useful. So next patient, a lady with fever and cough for 2 days. Anything abnormal? Any black or white bits that shouldn't be there? So as I said before, when you go down the lungs, it's supposed to get more black, although there's always overlapping shadows like the breasts, right? But if you compare the right and left side, this is more white compared to this side, yeah? But you can see the hemidiaphragm. Does that mean you're wrong? No? What aren't you seeing? You can see a hemidiaphragm, so it's probably not left lower lobe pathology. You can't see the right heart border very well, so it's a middle lobe pathology, yeah? And then you can see that lateral, a nice wedge shape. So that's the middle lobe. Is that the normal size of the middle lobe, do you think? It's a lot smaller, right, than you usually expect. So this is a middle lobe collapse. If it's consolidation, you shouldn't have any volume loss. It should still be the same volume, but just more white. If you go back on the frontal, the hemidiaphragm is actually a bit higher than what you normally expect. And also a right lower lobe bronchus is a bit more pulled down compared to normal. So again, it's all indication of volume loss. So this right middle lobe collapse, especially in an older patient, you really need to follow these up, because a lot of times the cause of the collapse is because there's an underlying interbronchial lesion. So you really need to make sure you do follow up Xrays, or you do a CT to make sure there's no underlying mass causing the lobar collapse. So patient is a trauma, so you probably use an ED. So a patient came with Highspeed MVA. What do you see? Lots of abnormalities here. So a lot of gas in the subcutaneous tissue. So a lot of left subcutaneous emphysema. And there's all these rib fractures. Consecutive rib fractures, probably not a flail segment because it's only in one spot. There's a pneumothorax, that's the lung edge. And there's a large pneumothorax because the endotracheal tube and the whole mediastinum is shifted to the right. So it's likely that they've got a tension pneumothorax. Tension pneumothorax is really a clinical finding. We can certainly suggest it on an X-ray, especially if there's mediastinal shift, but we've had patients with a clinical tension pneumothorax, they come in for an X-ray, and there is a pneumothorax there, but there's no mediastinal shift. So we don't tend to use tension pneumothorax in our report per se, because that's not really a radiologist diagnosis. That's more clinical diagnosis. But we can certainly say there's mediastinal shift. There's quite a lot of volume expansion on that left hemithorax. And especially in this such an extensive trauma, you want to really look at the aortic arch to see whether you could see an aortic arch, because you want to make sure there's no vascular injury. If you've got blurring or not poor visualization of the aortic arch, you probably need to do a CT to make sure there's no aortic dissection or a transection or other aortic hematoma. Okay. So this is probably more something you'll see very commonly: chest pain, shortness of breath, leg swelling. Probably don't even need to look at X-ray. You'll probably be looking very hard for a pulmonary edema. So what are signs of pulmonary edema? If it's cardiogenic pulmonary edema, you want to see a big heart. You want to see venous, what we call venous congestion, where it's upper lobe diversion of vessels. So usually, again, as we said before, lower lobes are bigger. So usually there's more air going into the lower zones, and what means more vessels will be going in, or there's more blood flow going into the lower zones. So in a normal patient, when they're standing up, usually there's more vessels in the lower zones. So if you see more vessels in the upper zones, that's abnormal. That means there's some diversion of blood flow from the lower zones to the upper lobes. And then you see all these fuzziness. Yeah, probably fuzziness. Probably not what term I'll use in my report, but this is what you will see. What we call perihilar consolidation. So around the hilum, a lot of sort of fluffy changes. And then if you look closely, if I zoom it up, there will be some curly B lines, and you can also see there's blunting of costochronic angles with pleural effusion. So this is gross pulmonary edema. It's not going to be subtle. And that will sort of correlate with the clinical history. So hopefully you give them some Lasix, that will get better. Next patient. So this is not uncommon what we do. The patient will be from cardiology. They come in for a pacemaker insertion. They put the pacemaker in and ask us to do a chest X-ray. So two things we look for will be the position of the pacemaker leads, making sure that it's all intact, there's no broken leads. So you basically have to trace, first you've got to work out how many leads there are, and then trace all the leads to make sure there's no broken bits. And you also want to make sure that it's in the right place. So in the dual chamber pacemaker, you want to see one in the right atrium and one in the right ventricle. Sometimes they do a lateral as well if they're kind to us. So we can definitely say, yes, it's definitely in the right atrium and ventricle. But otherwise, this is the normal position on the frontal film that you expect to see at 2 leads. So, okay, the pacemaker looks fine. Then we look for the complications. What complication can they get? A pneumothorax, that's right, because they can pierce the pleura. So there's a large pneumothorax here. The right lung is all collapsed. And then we will mention whether there's any mediastinal shift, which there isn't, even though it's such a big pneumothorax. So, okay, so this 2-year-old boy came in through emergency, sudden cough and wheeze after playing with an older sibling's Lego. So this is where the inspiratory and expiratory film comes in handy. On inspiration, looks relatively normal, equal lung fields, relative symmetry of density. Then on expiration, the right side looks white and the left side looks black. So which is the abnormal side? Where do you think actually, what do you think's happened? They probably swallowed the sibling's Lego, right? So where do you think it's stuck? Yeah, on the left side. Even though you can't see the foreign body, you notice the left side because the air is not getting out. Usually on expiration, air is getting out. So the lungs should actually be more white than on the inspiratory film. So that's the case on the right side, but on the left side, it's certainly more. It's probably not as black as it was on the inspiratory film, but it's certainly a difference between the left and right. So there's something stuck on the left side. The air's not getting out. Okay? So 27-year-old man, severe vomiting after heavy nights out drinking. What do you see? Normal? Then go home? What's all these black bits? And then you look down, it's black. There's a line of white outside, but there's black adjacent to the heart border, going up to the hilum, all along the mediastinum, going into the neck. So they've got air in the pneumomediastinum and also pneumopericardium. Yeah? Oops, sorry. So basically they've had like a really bad drinking, and then they just bad or very heavy drinking, and then there was severe bowel vomiting, actually tear the esophagus, a small tear. So you do a CT, sometimes you might see a defect, but you'll see a lot of gas in the pneumomediastinum. That's usually an indication that there probably is going to be a small esophageal perforation or tear. Okay? So I think a clinical history is very helpful. So make sure you really take a really good clinical history, and then when you get asked for an examination, whether it's blood test or imaging, you've got to know exactly what you're looking for. I'm just going, okay, chest X-ray is just part of the drill, so I'll just order it and I get it back and I'll just hope for the best that it looks normal. But you really got to know what you're looking for, yeah? Because sometimes it could be subtle. So another patient's motorbike accident, complaining of chest pain. We probably all know that the right side is more white compared to the left. What does that mean? So they've got consolidation. It's a supine film, so that means the patient is lying flat. So if the whole of one hemithorax is different density to the other, you've got to think about fluid. So especially in a trauma case, you need to think about hemothorax. Even if you don't see any rib fractures, in any trauma case, I mean, if it's not a trauma case, it could just be pleural, just normal, simple pleural fluid. I mean, you don't know on a chest X-ray whether it's simple fluid or blood or pus. But certainly in this kind of scenario, you'll be worried about hemothorax. You'll probably go on to do a CT to make sure you don't miss any other injuries. Okay. So this is a patient, young patient, another trauma case with low blood pressure. So firstly, we look at the lines. So endotracheal tube looks okay. It's a nasogastric tube. That looks okay. It's gone down the hemidiaphragm. So the lines look fine. Then what next? You know it's a supine film, but this still looks a bit big, right? And then you lost the normal aortic arch. It just looks like a big convexity, and then it's just fluffy in the left hilum. So I'll be concerned that there will be a vascular injury. On a supine film or an AP film, obviously the mediastinum always looks bigger. So I tend to ask the referring doctor, look, is that Highspeed MVA? If this kind of look, it could be normal, especially if you've got previous chest X-ray to compare. If previously the mediastinum always look a bit big because they've got an aortic aneurysm, then you just go, okay, this hasn't really changed over the last couple of years or over 10 years. But if it's the first time, it means he's 37, so he's probably unlikely to have a chest X-ray in hospital or anywhere. You have to raise that possibility. And I mean, we tend to have a low threshold doing CTs anyway on trauma patients, just because you don't want to miss anything, especially like vascular injuries where it's life-threatening. So they go and get a CT, and this is the abnormality. There's an aortic transection. This is ascending aorta, descending thoracic aorta, and you should not have lines going through it. In the lumen of the fat vessels, you really should not have any lines going through it. If it's a contrast study, it really should just be all white. So you really want all the vessels to look like this. Anytime you have lines going through here or along here, sort of more longitudinal, you'd be worried about aortic. I mean, there's a transection, but if it's going more along here, if it's a non-trauma case, you'd be worried about aortic dissection. Yeah? Okay, I think that's it. Any questions? Okay, good. Thank you.